Okay, sorry about that. It kind of cut off abruptly, but we were talking about traction. So this is part 2 of chapter 41 and 43. We are going to pick up on traction and the reason that you put somebody in traction and the challenges that becomes for a nurse. So like I was saying, when a patient is in traction, it typically requires 3 nurses to pull that person back up in bed. You need 1 person to maintain the traction. And so who's ever maintaining the traction down at the foot of the bed, they can't lift it up so much that you're not leaving enough traction, and you can't pull the patient up in bed and leave the traction down here because now you're going to do this to the joint. So lifting and moving a patient that is in traction, that is immobile, becomes a huge nursing problem. When your patients are immobile because of a broken bone, like your hip fracture patients, they should not be moving beyond 90 degrees. So they have a lot of devices now, like devices that people can put their socks on without having to bend over, tie their shoes, pick things up off of the ground, because you don't want to put excessive flexion on that hip joint that's been broken. So a lot of times they will be laying in bed and you as a nurse and your nursing team can log roll them. They don't do this on their own. If the patient's in traction, they've got a broken bone, so the leg will be out in traction, and they can use their good leg to kind of lift up their hips and buttocks so that the nurses can assess their skin on the back, because you don't want them twisting, you don't want them breaking traction. So prevention of decubitus ulcers is really important. Loss of muscle tone, deconditioning occurs very quickly. So you're going to want to do anything that you can to maintain the patient's level of conditioning while maintaining alignment of that bone, and it becomes very challenging. We're going to talk a little bit more about that as we go on, and I'm going to show you some pictures of traction. So when a patient is ordered to be in traction, first rule of thumb, you've got to keep them in traction until the physician says they don't need to be in traction anymore. You don't want to cause external rotation of that skin. So if they're on skin traction, I'm going to show you what that looks like. If the weights start moving off to one side or the other, it'll pull that whole bone over and can start causing some external rotation of that hip. They should always be in a supine position, which, as we know, is horrible when we leave our patients in one position all the time. So your nursing needs to become very creative to prevent decubitus ulcers from forming. And when the patient's in traction, it actually is less painful for the patient because of those things like I was just talking about. This is something called Buck's traction. So sometimes traction can be internal, like those pins that I showed you that go right into the bone. Sometimes they put traction on those pins and pull them that way, but a lot of times the device is external, and then they'll put the weight down here. So this leg is in traction in a boot, and then the boot is attached to the weight, and the weight is going to be dropped off the end of the bed. And you also have to make sure that weight is hanging and not dragging on the floor, because now the patient's out of traction. This turned out a little bit blurry, but I think there's a picture, a figure, a diagram in your book that kind of describes this. Your patient, there's several different kinds of traction and different positions that they will put a patient in depending on what bone is broken. Now this one, I don't think you can see it. Either Google it or remind me in class and I'll tell you what this looks like, but this is called a halo. So your patients who have spinal cord injuries, sometimes what they'll do is they will put them in a halo, and that's basically an external fixation device where there's a metal halo, like they call it like an angel. You know, the angels have a halo around them. It's this metal device, and then they drill screws through this thing right into the skull, and so there'll be 2 here and 2 in the back, and then the braces, the metal bars come down like this and then attaches to just sort of like a vest that goes over the shoulder, and it just keeps that head in perfect alignment until those spine the spine is fused, and so and sometimes in the traction, then that time the traction will be off of the head of the patient. So there's a bunch of different kinds of traction depending on what bone is broken, what actually needs the traction. But if you ever get a chance to go onto an ortho unit, their beds they just look like little gymnasiums. There's stuff all over because there's all kinds of tractions and weights and pulleys and all kinds of things going on. One thing that a lot of the orthopedic units have are these things called trapezes. This is a trapeze. And you'll notice even in my blurry image here that a lot of these beds will have trapeze on them because this does a couple things. One, the patient can help pull the patient up in bed by using the trapeze this way. The other thing, the patient can do some biceps and tricep works out here, so while they're immobile they can at least be moving their upper body. They can use it to lift up and keep these like legs or bones in line, and that way the nurse can get under and assess the back, put a bedpan under, change the linen, stuff like that. So a lot of these will have trapeze on, but I wanted to just at least show you what that trapeze looks like. They're really valuable. Crutches. There's a bunch of different kinds of crutches. I'm going to do another crutch video in a little bit, but they come in a bunch of different sizes and shapes. These are going to be your patients that have leg fractures. Okay, so now I want to talk about complications. 9 times out of 10, your patient is not going to have a complication from a break. As the break gets worse and as the treatment becomes more complicated, like when that break requires internal fixation, external fixation, traction, things like that, an extended hospital stay, now the complications can start getting a little bit worse. So that's what I wanted to talk about next. The first thing I want to talk about is compartment syndrome. Compartment syndrome occurs inside the muscle. It is more common in your fractures that are not open, but what's happening is the compartments of the muscle, I think I have a picture, yeah. So the compartments inside here, now this is what your, like if you did a cross section of your your distal leg for your tib fib, this is what it looks like. You've got your skin here, and then you've got your muscle compartments in here, and you'll notice you've got blood vessels, arteries, and nerves all spotted throughout here. Well, what happens when these have been injured is the muscle will start swelling into these compartments, and it starts compressing on those arteries and blood vessels, and you start getting excessive amounts of pressure in there. And it kind of does that same thing, remember when we talked about cardiac tamponading and things, where it has nowhere else to go, and the swelling happens so fast that it kind of tamponades back in on itself. Very similar to when we talked about burns, and the burns start developing eschar, the scarring, and then it compresses down on the fascia, nowhere for it to go. Then they have to do a fasciotomy. In a situation like compartment syndrome, sometimes what they have to go in and do is a fasciotomy, where they will go in and they will just cut the fascia, because this is a tight, like a tight cord. But what's happening in compartment syndrome is compressing here, so you will see numbness, tingling, cold fingers distal to wherever the compartment syndrome is occurring. That's how you know it's occurring. And so what you want to do, if you suspect that compartment syndrome is occurring, and you'll suspect it by those things I just said, numbness, tingling, discoloration, like a purplish discolor, you start worrying that compartment syndrome is occurring. And again, you're going to want to not necessarily elevate it, because you want the arteries now to get as much blood supply, and if you lift it up, now it's fighting against gravity, but at least at the level of the heart. A similar rationale behind applying ice, because typically when a patient is starting to swell, we add ice because ice reduces inflammation. However, if compartment syndrome is occurring and you add ice, now it can also cause vasoconstriction, and the problem in compartment syndrome is it's actually compressing the arteries and the vessels. So really what you want to do is, one is to prevent it, try to treat it with things like anti-inflammatories and steroids. If that doesn't work, you may have to do a fasciotomy and open this up to allow for release of that pressure, which pushes the pressure up here and allows perfusion then back down distally to wherever the compartment syndrome is occurring. This is an example of what it looks like. Obviously this person is very significant trauma, multiple broken bones, multiple external fixation devices, and here you can see along here they had to do a fasciotomy and open this up, but you can see the significant swelling in here. And so they had to go in and open this up. So see how swollen this is in there? So they just open it up. Now, if you're taking care of this patient, you're the nurse, you have significant responsibility to keep this clean. This is such a high risk for bacteria, you know, and so this, and painful, you know, so this becomes quite a nursing challenge. So how do you know that compartment syndrome is occurring? There's 6 P's that alert you that this is occurring. Paresthesias, by paresthesia I mean numbness and tingling. That's what people say they're having pins and needles in their feet. That's a paresthesia. It's like a weird numbness, tingling. They will have pain distal to the injury that's not relieved by opioids or analgesics. So the injury may be occurring here, but now they're starting to get pain down here because of ischemia. Remember, I've told you ischemia will always hurt. And opioids and analgesics don't take away that kind of pain typically. There will be a lot more pressure in that compartment syndrome, like I just showed you. Pallor meaning color. They will start getting, it will either get blue or white in color. The color will not be normal. Paralysis is loss of movement. They won't be able to move it because, again, those nerves are getting compressed. And pulselessness. So if it's starting to compress there, you're not going to be able to feel those pulses. So those are the 6 classic signs that compartment syndrome is occurring. Figure it out very quickly. Don't elevate it this is when you're going to want to just keep it normal. You're going to be careful with cold. I already told you about that. This is another complication that can occur, especially in your breaks that happen in the distal humerus or proximal ulnar radius. And what happens in some breaks in this area is something called Volkmann contracture. And this occurs again because of ischemia down here to the forearm, and then the muscles start doing like this really weird contraction thing like that. And if you don't, here's a good picture. You see where the break occurs here, and then it kind of causes this massive trauma and disruption to the muscle and causes these hands to start curling up like that. So one, you want to identify that it's occurring, prevent the ischemia, and then repair this as early as possible in order to prevent this. If it's not fixed early enough, this can become permanent. So you might see that in some regions that don't have adequate access to health care, specialized hand surgeons and things like this. The next thing that you want to watch for in your patients, especially that have fractures in the femur and tib fib, are venous thrombosis. So, and in your patients who are in traction, laying in bed, this is a huge risk factor. You know when patients are immobile and they're not up and walking, they are at huge risk for developing blood clots. Now remember, this is on the venous side, so when your patient's immobile, if they're in traction, if they're not moving those legs, they're not compressing those muscles around the legs, they can develop venous thrombus. How do you know your patient's getting it? Well, if they have a cast around their leg, that becomes difficult because you can't assess that leg is getting bigger. You can, sometimes they'll have a little bit of pain like a DVT, like they'll complain of pain in their calf, but not always. So one, you want to identify that they're at risk. Make sure that they are on things to prevent it, like blood thinners if they're in the hospital, maybe a little bit of heparin, a little Coumadin if they are on casts at home, things like that. And you're going to want them to do as much muscle movement as possible, even like squeezing their toes and squeezing their thighs just to keep those muscles moving, and then to identify it. And the classic symptom, if this this thrombus, this venous thrombus, falls off, what's going to happen to your patient? They're going to have a PE. And you remember why is because that little clot is in the venous side, and it's filtering all the way up through the venous side, up through the subclavian veins, right atrium, right ventricle, right into the lungs. So this is going to cause a PE. So if your patient all of a sudden starts complaining of difficulty breathing, shortness of breath, air hunger, anxiety, they may have thrown a PE. So you call for backup. So that's another thing you're going to want to watch for. Very, very similar to a DVT, but different cause, is something called a fat embolism. They're not 100% sure why patients who have had long bone fractures, and this is especially common in the femur, which is the hardest bone in the body to break. But your patients that have fractures in the femur, sometimes the tibia, can develop fat embolisms. And basically what this is, they're like I said, they're not entirely sure why. They think maybe it's like an acute episode of like thrombocytopenia, or, you know, they're not sure. But anyways, what happens is a little piece of fat is thrown into the venous system and can act very similarly to a DVT, and can land up in the lungs and cause a PE. And they're not entirely sure why, but you do need to watch for this in your patients who've had long bone fractures. And this is not going to occur within 24 hours. So this is, if you're working up on the floor, you're not going to see this in the ER unless your patient already comes in with a fracture. But if your patient comes in following a trauma and then is up on the unit for at least 24, this usually doesn't occur for about 48 hours post-injury, between 48 and 72, 96 hours, that's when you're going to start seeing this fat embolism. One thing that you'll see with fat embolism is chest petechiae. So all of a sudden you'll get all these like little red pimples and dots on the chest. That is an ominous sign that the patient has thrown a fat embolism. You're going to call for help immediately if you identify this. Your patient will have air hunger, anxiety, their O2 sat will drop. You immediately put that patient on oxygen, call for help, sit them up if you're able to. The patient may have to be ventilated, and you're going to call the rapid response team in order to save that patient's life, because that can be really scary. They'll have like some chest pain, their heart rate will go up, they will be hypoxic. These are all classic signs of fat embolism that you need to watch for in your patient who, especially if you have long bone injuries. The next thing is infection. We've already talked a little bit about infection and what causes these infections. Be especially vigilant of infection if the nature of the trauma was such that the patient was exposed to the elements. So, for example, your motorcycle accidents. A patient is out riding their motorcycle, bad crash, and they're scraped all along the road, or they're on a motorbike, they're scraped all along the ground. Well, there's tetanus everywhere. There's dirt, debris. So one thing, if your patient doesn't know when their last tetanus shot was, they need to have a tetanus shot, cleaning the wound, and then the surgeries can lead to infection. Pinning can lead, the external fixations or internal fixations, those could cause infection. Can lead to osteomyelitis if the infection gets in the bone. Much more expensive if your patient develops an infection. Sometimes the patient has to actually have an amputation, and in which case we've got really good prosthetic limbs. Your book doesn't talk a ton about amputation, so I'm not going to go into a lot of detail there. Just know that your job as a nurse is to do some good stump care. You're going to want to wash it, warm soapy water. As that's healing, eventually that will heal up, and it can slide right into prosthetic. Sometimes they'll put the prosthetic limb on right in surgery so that the stump will mold into that prosthetic limb. So I don't want to talk too much more about that because your book doesn't. Hip fractures, I do want to talk about this. You do need to know a little bit about hip fractures. Very common in the elderly. We want to prevent this in our elderly patients. because like we talked about with osteoporosis, if they fall and break that hip, it can fracture very easily. And again, you're going to watch for things like one limb is lower than the other, immobility, external fixation, or external rotation of the foot. Those are all classic signs of hip fracture. And again, you're going to want to distally assess the arteries, the pedal pulses, making sure that the arteries are intact all the way down to the feet following a hip fracture. And then what they can do sometimes, depending on how bad the fracture is, or if somebody has hip dysplasia or really bad arthritis in their hips, they can do a hip replacement. This is actually much easier to do a hip replacement than a knee replacement. There are a lot of different kinds of artificial joints that they can put in. Like this is just like a ball and socket. They'll put the socket up here in the hip, and this ball joint goes right down into the femur, and they just hammer it right down in there, screw this up into the hip joint, and then the patients, both the hip replacement and the knee replacement patients, we have them up walking within hours of that surgery. So you're going to treat them for pain, so they're able to get up, walk, and then you're getting them up walking right away, so that one, they stay mobile, two, the artificial part starts molding into the bone. So, and then they go for rehab. But there's a bunch of different kinds. Sometimes they will, this is another kind that they would replace, kind of like a ball and socket. This goes right down into the head of the femur. This one is a repair, where you can see that they have put the screws into the head of the femur and screwed it up into the hip itself. So this one they've repaired rather than replaced. And like I said, there's a bunch of different kinds of hip replacements. This is like a ball and socket. This is like a little disc that sits up in the hip, and this kind of goes into this part here. So, and that's it. So that's what I want you to know about musculoskeletal stuff. I know it's a lot. We covered a lot of chapters, basically chapters 40 through 43. And I know there's the videos are long, so what I would suggest is listen to the videos. The stuff that I talked about in the videos are important for you to know. If something is confusing, go back and look at your book. I would read the tables and the figures that are in your books. And then just make sure that you understand all the stuff that I was talking about. If not, bring your questions to class and we can talk more about it there. So, okay, we're done with ortho stuff.